There we go. Okay, I think I'm on the ball here. You'll see Ellen show up behind me every moment when I have this desperate look on my face. So let's go ahead and get started. So TB in man have had a long and sordid history. And as you can see from this picture from a mummy that was excavated from ruins in Egypt, it's been there for a long time, affecting mankind. This mummy shows probably the earliest signs of TB that we've ever had in recorded history, where you can see the sort of humpback that's there from the kyphoscoliosis caused by tuberculosis, most likely Pott's disease. And then you can see on the right side of the sort of frontal view where you've got that sort of cavity there. That cavity is probably from a psoas abscess. So this man was probably a high priest and someone of quite some significant prominence, had extensive TB disease, and it was probably led to his demise. But why did this guy get TB? Why him and not somebody else? Why at that time? Why was TB not such a big deal with mankind until later, when there was a little bit more urbanization that occurred? So to understand this, I think it's important to kind of look at the epidemiology, and then we'll kind of move through with that, talking about pathogenesis and transmission. Again, some very basic things, but also hopefully will give you some insights that you've not had previously, and also put things into the proper context. So again, probably a very familiar slide to many of you that talks about the distribution of TB around the world. So a lot of times, many of you will be in positions to evaluate patients from high incidence areas, and many will ask, say, well, especially new staff will say, what is a high incidence area? Well, pretty much anywhere outside of North America, Western Europe, and Australia is considered a high incidence area. Middle range areas, as you can see from the map, would include much of Latin America, where many of the foreign-born in the United States come from. But also looking at Asia and sub-Saharan Africa, you have substantially higher rates. And what you see in sub-Saharan Africa on this map is sort of masks the true reality of the epidemic there, where you can have rates in parts of sub-Saharan Africa, particularly in South Africa, that approach 1%, 1,000 per 100,000 population per year. That is an outrageous amount. And that is something that's being driven by HIV, as you'll see later in this talk, and also you'll see in the second talk this afternoon after lunch. In the U.S., a different story, and I love showing this slide because it shows you one thing, that public health is purchasable. You can look and see when public health funds were reduced, and you can see exactly when investments in TB came back. So look at the peak that occurred around 1991, 1992, and that was when investments started to happen with gusto in the United States, and you can just see the rates continue to drop. That little tail at the end, where you had a more significant drop in 2008, was an object of a lot of discussion. Was it because of H1N1? Was it because health department staff, such as yourselves, were doing H1N1 related activities? Was it because of the economy and fewer immigrants? It's unclear, but it probably had to do with a lot of these factors. And the fact is, y'all can pat yourselves on the back. You're doing a good job. Our goal is to eliminate this disease, and you're doing a very, very good job at that. But again, as you know, that there are certain populations where it's still not being eliminated, and still pockets where the disease continues to persist. So just with that very, very brief sort of clip note version of epidemiology, let's talk a little bit now about pathogenesis to understand why TB is occurring in the regions of the world that it is, that it continues to occur, and then what are the drivers behind that, both in the U.S. and around the world. So very basically, it's just that, and always when I give a TB talk, I tend to cough a little bit towards the later part of the talk after I get over, my mouth gets a little dry, so the front row always backs up a little bit by then. So you have no risk of getting TB transmission from me today, because I'm 500 miles away, and the only way to get TB really is by breathing in infected air. So it's the droplet nuclei, and as much as I would love to say that I don't spit when I talk, that I don't generate anything outside other than the words that I'm saying, the fact is that when we all talk, we generate droplet nuclei. It's more when you cough or forcefully exhale, when you sing, anything more forceful, but generally you are generating an aerosol as you breathe. Those droplet nuclei, to sort of put what 5 microns are in perspective, it's about the size of a red blood cell. So it's very, very tiny, microscopic. The spit that you might see when someone's talking, or the dirty utensils that someone might use after eating, those are not going to transmit TB because this is a respiratory disease. It's something that you're going to get from breathing in these droplet nuclei, which carry within them 1 to 10 bacilli. A single bacillus can cause disease, but generally the thought is that between 5 and 200 are needed to cause infection. Now, how they actually calculated that, and there's going to be a lot of variability depending on where that occurs. There's a lot of sort of fudge factor in there. But the fact of the matter is that people who are susceptible, when they get exposed to as few as just one bacilli and a droplet nuclei, is sufficient to cause disease. Once you breathe that in, it's not that it gets on your lips or in your throat. It goes all the way down and past the trachea, past the next generation of bronchi and bronchioles, but actually way down into the subpleural foci within the alveoli. As that kind of goes there, then it triggers the immune response. Once you get into that alveolar space, the bacilli are then ingested by the non-activated alveolar macrophages. So in other words, the lungs' garbage men come by, scoop it up, and then go ahead and deposit it within the immune system and start to attack it. Now, depending on the person's innate immunity, some of that has to do with genetic exposure historically to whatever that person's genetic background is, they may or may not destroy it. If they are of a population that TB is relatively new, they won't destroy it, and there's a chance that the alveoli are not going, the macrophages are not going to be sufficient in killing off the organisms. And then they multiply. And then gradually, over time, and I'll go over this a little bit later, in a couple of slides later, but you eventually develop cell-mediated immunity. So what is cell-mediated immunity? It's essentially you have a positive skin test. You get your lymphocytes are activated. They now determine the ability, they now have the ability to attack tuberculosis and start the process of containing the infection. Again, if the person is immunocompetent and able to fight off the infection. Now, generally, I say here it occurs within 3 to 4 weeks, but just think about the time windows when you're doing a contact investigations. Contact investigation can be anywhere between 2 and 12 weeks, 2 and 10 weeks, really. So that's the time that there will be variability in developing that cell-mediated immunity. The peak is probably about 3 to 4, as I mentioned here, but anywhere between 2 to 10, 2 to 12 is when it really occurs. Now, this is a pathologic specimen of a chunk of lung, basically, that shows a subpleural focus, and it's that white area that you see to the right of the screen that has a calcified, not a calcified lymph node, but a calcified granuloma that over time, cell-mediated immunity formed a granuloma. We'll look at some of those under pathologic slides in a moment. But over time got calcified and ended up being a non-infectious area of contained tuberculosis. Whether or not that person developed latent TB infection or not is not completely clear. But again, that's generally what will occur in the periphery of the lung tissue. Now, this x-ray may be a little difficult to see even with the little arrows there, but this represents, you may hear x-rays that have reports of a Ghosn focus or Ranke's complex. Those are names or eponyms related to radiographic findings that really don't indicate active disease. More commonly, you'll read an x-ray report that will say something to the effect of granulomatous disease present. And be wary of those x-ray readings because really that doesn't mean anything other than that the granuloma is present. Typically what you'll see is that on the more peripheral arrow that's out towards the right side of the image, on the periphery of the right lung, that's a single granuloma where you hit that subpleural focus. Now closer in, at the highlands, that closer in, more medial arrow, that arrow represents the granuloma that formed at the lymph node. So you've got this immune reaction at both ends where it was the entry point and then where it was introduced into the immune system, and you get an immune reaction localized there. This does not indicate active disease. This is typically what's found in people who've had a significant immune response to a TB exposure. Not everybody who has latent TB infection has granulomas visible on x-ray, and not everybody who has this appearance necessarily has latent TB infection. It's just a common finding seen with that. So now remember that exposure to a person with active disease results in infection about 1/3 of those without HIV. Now that means that they develop a positive skin test. Do they develop active disease? Certainly not. But when you think about the attack rate, that is, after being exposed to an infection usually, what percent will develop active disease? It's very, very low for TB compared to, say, influenza or measles. Think of the last time you were in the house with somebody who had the flu. About 70 to 80% attack rate. When you've got the flu, you've got it. When you've got latent TB infection, you don't really know. And again, even only 1/3 of those that are close household contacts will have positive skin tests. Now remember that that's, again, inactive disease or latent disease, but only about 3 to 5% of those that will develop TB within 1 year, that is, those that were latently infected, not of the total population, and only 3 to 5% at some point thereafter. So even at best, in most populations, if you're immune competent, you're going to have about a 10% lifetime risk of developing active TB disease. So this is that pathologic specimen that I referred to earlier. And this is a tuberculous granuloma seen on a biopsy of lung. This is a small granuloma that may or may not have been visible radiographically. But you can maybe sometimes hear when you read pathologic specimens of active TB cases where it talks about these whorls, these multinucleated giant cells. It's basically the immune response once cell-mediated immunity is in place, where lymphocytes come in, they stimulate fibroblasts, and they come up with these very typical scars and pathologic manifestations. Now remember, not everything that causes a granuloma is TB. There are a lot of things that are going to kind of mix things up a little bit. Most commonly, especially in the southeast, is going to be sarcoidosis. We're looking at this specifically like that as it appears here. This could be sarcoid. It could be any one of a number of things that can cause that granulomatous response. Tuberculosis is sort of the most important in many ways because of what it leads to eventually. But again, this is just a very general type of response that you will get caused by cell-mediated response. You'll also hear pathologically hear the term caseation necrosis. This is caseation, I think, sort of has this meaning of sort of this cheese-like appearance. I don't want to get into that, what that would actually look like. But in the gross section of a necrotic area where there's this cheese-like substance that can be fairly foul-smelling as well because of the necrosis of the tissue itself. And this is what you end up seeing. And this is a little bit more indicative of tuberculosis, but it can still be seen in things like sarcoid, more uncommonly things like borreliosis and other granulomatous causing infections and non-infectious environmental causes. Now, just to review, I know this is very basic and very much a review for those of you in the room who do a lot of TB, but really just I want to emphasize this point because many of the patients that you deal with and the healthcare providers who don't do TB will get tripped up on the nomenclature because tuberculosis is really the only disease that we commonly deal with where infection doesn't mean disease, and infection just means this latent state. So just emphasize to your patients and to those other healthcare providers that it cannot be spread to others. They're not considered a TB case per se. They have a positive skin test reaction or an IGRA, or interferon gamma release assay positive test. Their X-ray is clear. That means also they might have granulomas, but granulomas do not indicate active TB disease. You have to have the fibronodular or alveolar component in there as well. And we'll look at some X-rays here in this presentation and in the next one as well. And they have no symptoms by definition. They do not have active disease. They have viable mycobacteria that are living within their bodies, but not causing any type of pathology whatsoever. But the real key here is the potential for active disease, that it can lead eventually to active TB disease. Now let's talk about that. So we've already established how you can get exposed. We've already established the fact that what latency really is and how that sort of comes about in sort of a broad overview. But now let's talk about disease progression, because what really doesn't bother us whether or not somebody's PPD positive, right? That has no impact on that individual's health or the individual public health of those around them. But the issue is, what about that disease progression? How do we identify that? What do we do about it? How often does it occur? So disease progression from infection to disease is caused by an inability to contain the infection. It can occur when that first bacilli goes all the way to the subpleural foci that I talked about within the alveoli and then progresses, or it could be what is referred to a lot of times as post-primary. That is, that you don't have primary disease from that initial infection, but that you have a period of latency that then moves forward. So 5 to 10% of HIV negatives we reviewed before will eventually develop active disease. So from the pool of about 10 to 15 million people in the United States who have a positive skin test, about 5 to 10% of those will develop active TB disease at some point during their lives. Now, when you contrast that with HIV positives, it's up to about 8% per year of TST positive, HIV positive patients. Now, that has changed a little bit with heart therapy. That has really reduced it, but you're still, despite effective heart therapy, despite having a good CD4 count, HIV positive individuals are going to be at increased risk for progressing to active disease. This next stat is something that I've seen in many different places, but really to try to find the reference is challenging, but it's commonly said that the average TB patient will infect 30 other individuals who are PPD negative and convert them to positive before they start effective therapy. I'm not sure how true that is, but it's something that's often quoted. When you try to find the reference, it's a little bit more difficult, but it's not that far fetched to believe that somebody can infect that many individuals before beginning appropriate therapy. Now, what are the medical conditions that cause you to progress to active disease? HIV drives the bus. That's why it's here in red. Nothing has changed the face of the TB epidemic worldwide as much as HIV has. In our settings, where immunosuppression is caused as commonly by transplant or treatment of inflammatory-mediated diseases such as rheumatoid arthritis or Crohn's disease, immunosuppression from those medicines, including the TNF-alpha blockers, is becoming an increasingly common cause of immunosuppression that may lead to progressive active disease. Silicosis, very uncommon nowadays, but has to do with exposure to silica dust. Diabetes, chronic renal failure will be the two probably the most common ones that we'll end up seeing. And I didn't turn my phone off after the break, so I apologize. The other one is the issue related to some hematologic disorders, weight loss greater than 10% of their ideal body weight, and then also those that have had a gastrectomy. Gastrectomies aren't as common now, but still occur with some people who are alcoholics and have bleeding peptic ulcers. But also, you probably would throw in this group people who have had stomach stapling and have lost a large amount of weight. Those folks, if they have latency and then lose large amounts of weight after stomach stapling or other procedures related to that, can actually develop active TB disease and also bypass and other malignancies. Now, interestingly enough, cancer of the lung does cause it, but also as much, not just from the immunosuppression, but sometimes from just eroding directly into a foci of latent disease. So if there's a granuloma, it can actually progress and then activate disease locally. And about 2 to 4% of active TB patients, in our experience, have concomitant lung cancer. So some of that has to do with the scarring, some other issues, but just remember that these are individuals that will be increased risk. So let's focus a little bit more now on HIV and how it makes TB worse. Again, this is very basic and very review for most of you in the audience, but just wanted to kind of emphasize this point to your co-infected patients and those that you're screening. And that's an important point as well, that we don't do as good of a job checking HIV status on people who have positive skin tests, which, again, needs to be done routinely just so that we can identify those that are at greater risk. Without T cells that you would lose through HIV infection, you get an immature response to the mycobacterial exposure. So in other words, you don't get a good enough response, and we'll see some examples of that where you don't get that typical area where you can protect the granuloma, have a normal forming granuloma that sequesters the infection and then causes the latent state. Again, when it goes to the lymph node and you're trying to develop cell-mediated immunity, you then can disseminate because you have hematogenous exposure as well. And then also you have a greater chance of rapid progression from sort of active disease after recent exposure. So in other words, if you have a large group of HIV positives who are exposed to an active case, you may not have a very long latency period if you have a latent period at all. So just remember that. And then also there's the idea of acquisition of greater chance of acquisition of disease if you've lost your innate resistance. Remember when I mentioned about the garbage men, if you will, the macrophages within the lungs, those are going to be affected by HIV, not quite the same way as the CD4 lymphocytes, but they will be affected and they may not be able to kill the mycobacteria on site when they occur before they get access to the rest of the immune system. Again, some of this is a review again, but again, you may lose resistance, not resistance of the organism, but the individual loses resistance that they once had, so that if they get re-exposed, they can get reinfected. So that's very common in places like Africa with high incidences of active TB disease, and there's a lot of disease within the community. But also it's important for those who might be repeatedly exposed. So if you have a prison that has poor control of active TB disease, there might be multiple exposures to people who are HIV positive. Again, we know that recent infection and moving on with post-primary TB disease is more common amongst HIV patients because of that re-exposure phenomenon. And then also, we'll talk a little bit about this with some actual x-rays, is that it changes the way it presents. It doesn't always present with that upper lobe disease that we talked about very commonly. And you may get, actually with severe immunosuppression, and I've seen this more times than I care to admit, where you have a completely normal x-ray and even a normal CT scan of the chest and still have 2 and 3+ smear positive specimens because the immune response is inadequate. Okay, so this x-ray is a typical looking x-ray. excuse me, of somebody with active TB disease who is HIV negative. You can see in the right upper lobe to the left of your screen where there's a large area of cavitation where there's just literally billions upon billions of organisms. And you see diffuse alveolar infiltrate. So this is clearly not going to be latent disease. This is clearly going to be someone who has the ability to produce cavities, which is due to the immune response, not necessarily to the organism itself. And this is a typical appearance. But by the same token, you can have this patient who is HIV positive who has very minimal disease, a little bit of patchy stuff in the left upper lobe, a weird pleural reflection along the left heart border that, again, indicates TB, but they can both have markedly smear-positive specimens depending on their immune status. So let's talk about cavitary TB, and unfortunately I'm talking about this part after lunch. Essentially, the cavities occur when there's necrotic tissue, and you basically cough out that portion of your lung. It comes up as just a very dark-colored sputum that is a mixture of blood, tissue, and inflammatory cells. And that eventually leads to the cavitation that occurs that you will see on X-ray, and then will harbor the organisms. So this was a pathologic specimen from a patient who died with active TB disease. It's more common in the upper lobes, but remember, in HIV positives, you can have very unusual presentations, including cavitation, less commonly so, but in the lower lobes as well. Now, this is a picture that you would see typically. This is a patient of mine that was from a high-incidence country in sub-Saharan Africa who had miliary TB disease. Again, miliary disease in non-HIV positives is usually going to be smear negative, but this patient was markedly smear positive. The pathologic specimens that you would see, fortunately not from the patient that I was taking care of, but from this atlas of pathologic specimens, shows that sort of granular pattern. And what that represents, that these are all tiny foci, little spots of active TB disease that have spread hematogenously. And you get this appearance in the lung, but that probably occurs in all the other internal organs as well, where there's just disease virtually everywhere. And the burden of disease is enormous. This has a very high mortality overall. And just for those trivial pursuit aficionados out there, this is what Eleanor Roosevelt died of, undiagnosed miliary TB disease, which carries a mortality rate now still above 15%. Again, these are the pathologic specimens that I talked to you about with TB and HIV. You can see the poorly formed granulomas where you don't get those nice whorls. Look over to the right of the screen. You see that very nice, well-circumscribed giant cell with the surrounding inflammation. Then look over to the left where you see it in an HIV-positive individual where they cannot form those granulomas. That's important not only from a pathologic standpoint, but most importantly just from a clinical standpoint. If you can't form those granulomas, the granulomas are key in being able to establish that latent period. Again, a little bit more of the same, but those little red snappers that you see, those little red lines, those are active organisms. So you can see that on the left, you could not, the lymphocytes and the macrophages could not kill the organisms and leave them and sort of eliminate them, whereas on the right, those organisms are a lot less common. So the burden of disease present in patients with HIV is going to be substantially greater. So let's shift gears a little bit and now talk about the transmission of TB disease, because really, ultimately, that's what's critical to us. We want to know how to break that transmission from one individual to another. So I've got the requisite cute little guinea pig slide in here when talking about transmission of disease, because the earliest studies really looked at guinea pigs as far as the perfect vehicle to document transmission. Guinea pigs are exquisitely sensitive to aerosolized TB, and with one single granuloma, with one single mycobacterial exposure to TB, they can actually develop disseminated disease and die. They don't develop latency, they don't fight off the infection, it's fatal. So it's good for us, bad for them, that they are a perfect model to sort of determine transmission. And in very elegant studies, I would encourage you to kind of look at that historically, where Riley in, I think it was the VA in Baltimore, got guinea pigs, put them in cages above the air vents of TB wards at the VA hospital, and then the effluent air would pass over, and you can tell which patient rooms were more infectious than others by looking at the guinea pigs. So you were measuring not sputum, because when you think about it, sputum doesn't transmit TB. We use it as a proxy to talk about how infectious a patient may be, but really what we care about is how much of that stuff is getting in the air and how much is being breathed in. So this fantastic study by Riley, which is considered one of the sort of landmark studies in all of TB and actually all of public health, really showed that it takes a lot of air. You've got to breathe in a fair amount of infected air, about 11,000 to 12,500 cubic feet of air. The infectivity, as many of you who do contact investigations will know, that you've got a lot of variability between your various cases. So you have some cases that seem to have a lot of PPD positives around them, and yet you have others that seem to have very few. And Riley's study was the first to really show that about the heterogeneity of transmission, where you had 8 out of the 130 patients that were on those wards accounting for almost half of all the transmission. That's huge, and that's very, very important to kind of consider that there's variability that occurs for a wide variety of reasons. And we'll review some of those here in a moment. Untreated patients with drug-susceptible TB were much more infectious, and that makes sense. They're still actively spreading the disease. And here's something that's interesting, that drug-susceptible disease is 4 to 8 times more infectious than resistant disease. Now, if I was there, I would play 20 questions and ask you, why do you think that is? But I want you to just pause for a moment and think, why would that be? I mean, the reason is that when you expose the TB germ to the TB drugs, it results in a lot of mutations immediately. So you're killing the organism. And you select out mutations that have already been present that may not have contributed to the fitness of that organism, that is, its ability to be transmitted, but may contribute to its ability to resist treatment with drugs. So again, TB that's been treated tends to have a lot of mutations selected within that population, and may, not always, but may be less infectious. There have been data since Riley's initial studies that have shown variability, but that MDR can certainly be very transmissible. But just remember that there is a lot of variability between patients. And also, very importantly, that UV light is very effective in preventing infection to begin with. And that was concluded in one of the conclusions of Riley's studies. So I put this cartoon here to sort of kind of summarize kind of the transmission. And here we have a gentleman on profile who has the large cavitary lesion in the upper lobe, as you can see from the lateral view. He coughs, he spreads. The UV light from the sun would kill it, so transmission out of doors occurs, but is exceptionally uncommon for a variety of reasons. Then also you can see how it's breathed in, and that you get inhalation. It goes to the distal alveoli, gains access to the bloodstream. The immune system works over time to develop that immunity, and then you develop that within about a period of 10 weeks. Now, transmission is going to occur for 2 main reasons. There's going to be characteristics of the index patient, that is, the gentleman there that was on the previous slide that had the cavitary lesion and was coughing, or the characteristics of the contacts. And we're going to talk about both of those groups here. So now, as far as index patient, just think about it. The more bugs you have, the more disease you have, the more likely you are to spread. So somebody who is smear negative and has minimal infiltrate is going to be theoretically less infectious and less transmissible than someone who has a large cavitary lesion and has extensive disease. But that's not to say that smear negative people can't transmit disease. And I really want to put an important caveat here. In very good and very elegant studies that were done in San Francisco looking at molecular epidemiology, about 17% of all TB cases were transmitted by somebody who was smear negative. And that's very important to remember, that contact investigations need to be performed in individuals who are smear negative. As long as they have pulmonary disease, it needs to be done. The duration of illness is obviously very important as well, and this is going to affect proximity. So if you live in a home with somebody, and if you sleep in the same room or sleep in the same bed, you're obviously going to be sharing air for long periods of time. Local air circulation. We had a very interesting case here where in Florida, similar to Alabama, but maybe more true here, that we have very mild winters, and the houses are not built for the cold. But it does get cold here for brief periods of time. And so I had one case where they were in a trailer home. It got very, very cold one winter, and they wrapped the windows in visqueen to sort of help it with insulation. Well, they invited a homeless man over for a Christmas dinner, and everyone who was in that trailer for a Christmas dinner over a 6-hour period of time was PPD positive. We had 2 active cases because there was no air circulation. There was visqueen on the windows, and they just went to show that no good deed goes unpunished. And they had so many active cases, 2 active cases, and I think everyone had converted amongst 20 family members. So again, local air circulation is very, very critical. There's other things that are important that have not been substantiated as well, and I think that probably the most important is the idea of virulence. Not all the mycobacteria are going to be as virulent. There are going to be some strains that are going to be more infectious to people than others. They're more fit for transmission. But again, trying to quantify that has been a challenge in many ways. Now, characteristics of the contact. So we know that basically if you have a lot of disease, if you're very symptomatic and there's not poor air or there's not good air flow, that you're likely to be more infectious. But the contacts are going to be important. There's two main things to remember here. It's age and immune status. So basically on the extremes of age, a lot younger, you're likely to progress the disease very quickly. And if you're a lot older, you're likely to be debilitated and have poor immunity and get reinfected or progress to active disease more quickly. That's why children under the age of 5 have that high priority after they've been exposed to an active case. And obviously the immune status is probably the big one with most of our patients. We know about HIV. We've kind of reviewed some of these statistics already. But also I really want to emphasize people that are on prednisone. Now this does not include an asthmatic who is on a 5-day course of prednisone, or even someone who might be taking it for, I don't know, let's say poison ivy exposure, who may need to be on it for a week or two. But basically, you're looking at a prednisone equivalent of 15 milligrams per day for 4 weeks. Organ transplantation, absolutely. Anti-rejection drugs related to transplantation, cancer chemotherapy, and the TNF-alpha blockers. Those are going to be very, very important, especially infliximab, etanercept, adalimumab. Those are going to be very important ones that can lead to progressive active disease after being exposed. There's other medical conditions that have a lesser effect after exposure, and we've talked a little bit about those already. So just in summary, the pathogenesis of TB is 2 stages. You got to get infected, in other words, you got to get exposed, and then be infected once you've been exposed. And then there's development of active disease, which means poor immune status either iatrogenically or because of your age or some other factor that's going on. The issue here about fibrotic lesions on the chest x-ray, that's important, but it doesn't weaken you by itself. That means that you've had active disease which you kind of contained, but you're still at increased risk because you've only marginally contained the disease. And I'll go into that more if there are further questions related to that, because it's a whole separate discussion. So, starts out, pulmonary TB, somebody has a cough, you generate droplet nuclei, there's the primary lung infection and the susceptible contacts, you get lymphogenous spread, which is for the most part asymptomatic, you develop cellular immunity and you have a positive skin test. 90% of people do not develop TB after that sequence. Of the 10% who do, 85% have pulmonary disease and 15% have extrapulmonary disease. So in an enclosed space, a little bit more about exposure and transmission. The circulation of air is going to be a big issue about the predictors of transmission. Remember what I said earlier, it's very hard to get TB out of doors. That's because there's such good airflow. But within inside areas, that's where most of the transmission, if not all the transmission, is going to occur. And one thing, I just kind of want to tip my hat to my colleagues there in Alabama, especially Bill Bailey, because he published a paper that was very important. It kind of went beyond the terms close and casual, things that we throw around all the time. But with his work and the work of many of you there in Alabama, kind of came up with this new idea, which unfortunately didn't get as much traction as I thought it would. But basically grades the amount of risk. And there was some very good data. I like this a lot and actually use this in my own practice now, that various grades depends on the size. It makes sense. So if you're in a closed-up car and you're in that for 12 hours a day, well, that's not going to be the same risk as if you're in a gymnasium with the kid for 12 hours a day for whatever reason, with a kid who has TB. I mean, so there's going to be a lot of variability within this, and this allows people to quantify it, to go beyond just saying, oh, I'm close. Well, what does close mean? What does casual mean? This kind of gives you that ability to communicate better, and unfortunately hasn't gotten as much use outside of a few settings. Now, likelihood of infection is going to depend on the intensity, frequency, and duration. So we talked about that. So let me use one that's a common example that comes up. It's about airline passengers. So with airline passengers, it's been looked at multiple times as far as what the risk is. In fact, this question came up to one of the counties that I provide TB service for, that, you know, how long is too long? And basically 8 hours is the cutoff when we think that the risk for progression or risk for transmission occurs. Does it occur in an hour? It could, but it's unlikely. And in that setting, and actually in the studies that review transmission on planes, that's been an issue. Then also there's another set of criteria that looks at like an hourly total. And this is something that I use as well when I'm determining a contact investigation to determine how to extend it or to continue it. I try to give them an hour of exposure cutoff and say, okay, these people have been around them for X amount of hours. Anybody who's been more than this amount, we go from there and then count up. and anyone who's less, we don't do in this circle of the contact investigation. So I'm putting this here to just sort of emphasize the point about intensity, frequency, and duration of the exposure, but also to emphasize the point of trying to put things in terms that are easy to communicate. So let's talk about the likelihood of infectiousness. Kind of something that you would think of probably being infectious, yes. Positive sputum smears with viable AFB, in other words, growing cultures, presence or induction of coughing, so in other words, if someone's symptomatic. Someone who's not being treated for TB, so the fresh out of the box, coming into the clinic for the first time, and either poor clinical response or their smears are just not getting better. And I would tell you that that's probably the least important in this category here at the top. Probably not infectious, 2 to 3 weeks of adequate therapy, and a definite clinical or bacteriological response. So if you see the patient back, they've been on therapy for 2 weeks, they were either in the hospital being managed by someone else, and they come in and they feel much better after 2 weeks, again, it's a dramatic difference. And their risk is probably going to be real low. And non-infectious, they've been receiving effective therapy and they're responding, and you've got 3 daily negative sputums sequentially. That's going to be an important thing to consider there as well. And when I say adequate effective therapy, this usually means at least 2 weeks of treatment. So here's an important question. I know that there are a lot of infection control folks in the audience, is when can I send them home? What they don't say is that when can I send them home because the utilization review is driving me crazy and that isolation bed is costing us a fortune. So here's kind of the broad outlines with this, is that TB is an outpatient disease. So to me, the main question is that why were they admitted to begin with? The most infectious day in a patient's course is the day before they start medicines. And so if they don't need to be admitted for social or medical reasons, or they can't take their medicines, then they don't need to be in the hospital to begin with. So it's not a good place for TB patients just because of all the other immunosuppressed patients that are there. And again, when you think about who they live with, they've probably already been exposed. Now, there are going to be exceptions to that. Newborn children, HIV positives, other immunosuppressed, those are going to be important individuals to keep in mind when sending them home. But again, remember that they most likely were already infected. And when you send them home on therapy, that's going to be a key piece. Send them home even if they've got positive smears, if they can care for themselves. There's no vulnerable individuals at home, as I just mentioned. And then also sort of a bridge, what we use here in Florida a lot of times is a motel. It's a lot cheaper to put them in a motel for the first 2 weeks of therapy if they're homeless or there's someone at risk at home. Put them there as a bridge until it's time that you consider them to be non-infectious. Now, I know I didn't answer the question as far as like exactly how many days and when do you send them home, but I wanted to kind of give you broad outlines to just sort of empower you, I hope, to be able to get people out of the hospital more frequently. Again, I really want to stress that this is in close coordination with the health department. The last thing you want is someone to be discharged and thrown on the health department Friday afternoon at 4:45 in the middle of a storm, and they're going home to their HIV positive brother and their newborn nephew. I mean, that's obviously not the setting that you want, but coordinate closely with the health department when you're discharging from the hospital. A little bit about strain typing methods, just to kind of very briefly touch on this, because I'm going to talk about it in my case examples here in a minute, is that this kind of helps us identify the sort of the path of transmission. Who gave TB to who? And so we can do this by DNA fingerprinting. So be careful with the term DNA testing, because DNA testing can mean everything from the nucleic acid amplification probe to the DNA fingerprinting that we use to identify strains and to identify clusters, to actually molecular-based methods to diagnose susceptibility to the different drugs. This is really important to be clear what you're talking about when you use the term DNA. The most common previously was I-6110. That's an insertion sequence 6110. It was sort of the first one. It was the most discriminatory, but it's very labor-intensive and very much a challenge to sort of get out there and compare different strains from different areas. And it takes a long time, and that's in the best case scenario where you get that 3 to 6 weeks. Spilica typing is less discriminating, but very easy technically. Miru VNTR is now going to be more commonly used, and is becoming the standard for discrimination and for it being able to establish true links. So it's going to be very important to kind of look at that data to sort of address some of these issues. Basic definitions: genotyping, also referred to as DNA fingerprinting, as I talked about. It provides a description of the gene makeup, essentially, that allows us to know how related different strains are. And a genotyping cluster is when those DNA patterns match. An epidemiologic cluster is then when we know that they were linked somehow, that both of these patients were at a bar, and we both got these cases within the last 2 months, and that they were on each other's contact list and did not take LTBI therapy. That would be an example of an epidemiologic cluster. So 2 or more cases together. So let me just talk about a couple of cases here. I may have presented these at some point to y'all before, but I think it's good for a review, and I know a lot of you are new as well. So let's talk about these 2 cases that seem seemingly related, or seemingly unrelated cases, and want to just kind of emphasize a couple of points. First one is case number 1 is a case of a 34-year-old woman who went to her local physician with fever, weight loss, typical symptoms of TB. At that time, she was found to have HIV disease. This was 1995. And then also she had retroperitoneal lymph node, which eventually came back positive for MTB. They did blood cultures on her, which were positive, so she was basically had disseminated disease, couldn't contain the infection, and was sort of bearing the price for that. The organism was demonstrated to be susceptible. She started on her meds, but then non-compliance came in. There was a long story here where her mother was a nurse and was supposedly doing DOT, but DOT was not DOT. DOT was DOPT, directly observed, actually DOD, or directly observed delivery, and there was no actual DOT that was done. And also the meds were being given incorrectly, so long and the short of it is that she developed adenopathy when she completed therapy, relapsed a year later, and had cervical adenopathy that was positive for Mycobacterium TB. It ended up being that her resistance, now she developed rifampin monoresistance. So directly related to her self-administered therapy, inadequate therapy, and she developed active disease. So chest x-ray showed in October 1996 that she had extensive disease, a lot of pulmonary infiltrates, presumably to the rifampin monoresistant strain, and then she died of respiratory failure later that year. So a tragic, tragic case. Now, enter the second case. This is a 48-year-old woman who developed shortness of breath and a dry cough in 1993, so 2 years earlier than case number 1. She had a chest x-ray that was suggestive of sarcoidosis. PPD was negative. Bronchoscopy looking for TB was also negative. And so she was identified as being sarcoid. Now, again, they thought sarcoid because she had these granulomas that were non-caseating, but granulomas that were consistent with sarcoid. Could have been TB, but cultures were negative, and the PPD was negative. She was treated for sarcoid, got prednisone therapy. Remember what prednisone does to the immune system. And she was lost to follow-up, but she did really well. You know, so in 3 years later, she did well, and she showed up again with more shortness of breath and a dry cough. She got prednisone and oxygen, typical therapy for someone with advanced sarcoid. She got a little bit better, but because she wasn't responding, she then got Cytoxan or cyclophosphamide to give her more immune suppression, and that will help suppress the formation of those granulomas. In April of 97, she got a bronchoscopy, and then the histology was negative, but showed that she had some poorly formed granulomas that were present, but no organisms, so no evidence of TB at this point. Cytoxan was stopped. She was treated for pneumonia, came back in to the hospital in June of 97, and being evaluated for her lung transplant. She had a bronchoscopy done right before her evaluation that grew out MTB 3 days before she died. So again, a tragic case, but she was rifampin monoresistant. So rifampin monoresistant is very uncommon, but there was no links between them. So we had a susceptibility pattern that we had a epidemiologic link. In other words, they had a strain that matched, and we couldn't explain why. No, they had a resistance pattern that matched, and we couldn't explain why. And we couldn't figure it out, so we decided to do molecular testing. And that kind of helped us identify and showed that they matched perfectly. So the bottom A and B is a spoligotype output. So that's actually the actual photo image of a block that comes up with the spoligotype. Usually it's represented by a digital sort of representation. And the top one is the RFLP, showing the 3 base pair fragments that match perfectly one with the other. So the question was, we've got an epidemiologic link. Now we have a molecular link. What do we want to know? I mean, how could these have been linked? They're totally different people, opposite parts of the county, had no obvious links between one another. And so we tried to dig a little bit more. And so what we found basically is that case number 2 died. She was a funeral director. And then when we found that out, we found out that case number 1 was actually embalmed by the funeral director who died. She developed disease later, and basically what happened is that she contracted TB disease because during the embalming process, there was aerosolization of the tuberculosis that was present in patient number 1's blood. So again, a very unusual case, but this occurs more commonly than we understand. And when you think about it, funeral directors have an increased risk of TB infection despite their high socioeconomic status. In fact, other than healthcare workers, they are the only people, only profession that has an increased risk of TB disease compared to their socioeconomic match. So again, you need to be very careful in these settings, and I'm not saying that this is a big problem that you need to address it, but I put this case there to highlight the uses of DNA fingerprinting, and actually the fact that it's aerosolization. It's not necessarily coughing. It's not necessarily any type of fomite spread, but that it can occur for a variety of mechanisms that can cause aerosolization. So another use of molecular fingerprinting here, I want to talk about another fascinating case, but sort of a larger group issue. This first one was a 50-year-old gentleman with a history of alcohol abuse who was treated for TB in late 1996 with directly observed therapy and some self-administered therapy. In my book, you know, it's kind of like saying you're kind of pregnant. It's just you either got therapy all by DOT or you didn't. And so I kind of consider it that this was self-administered treatment. So there is no kind of DOT. So he was for the most part complying with therapy, but had refused an HIV test. And that's obviously one of the biggest risk factors for HIV positivity is refusing an HIV test. In the spring of '97, he relapsed with TB this time and had a diffuse nodular infiltrate that you can see on this X-ray. Hopefully it projects as well there as it is here, but basically there's a fine granular pattern. We have a case of miliary disease here, although he does have a little focus of pneumonia in the right upper lobe there, just below the level of the clavicle. So again, disseminated disease in the setting of HIV. He was restarted on therapy, but because he wasn't taking his medicines and not complying with therapy, we got him committed to A.G. Holly State TB Hospital, where he did complete therapy. And what's interesting is that this is a small county in rural North Florida that had a case rate 3 to 4 times higher than the state average. It was higher than Miami at the time, which was remarkable. They had very high rates of HIV as well, and that was what seemed to be driving the disease at the time, or the epidemic. We did a more in-depth investigation, and we kind of looked and really couldn't find anything. And then we finally did RFLP, and at that time we weren't doing this pholigotyping, and VNTR was not available. But we found, we did the DNA fingerprinting on all the cases over a 5-year period of time. Got an output similar to this, which basically showed that every African-American patient matched, and there was very little agreement on the conventional contact investigation list. So in other words, no one showed up on anybody else's list, so we didn't know what was going on. So there's no obvious social links. It was a small town, but there was no common work or home exposure, and not really any obvious links between them. So we kept re-interviewing people that would come up. We tried to find the matched RFLP cases that were still available, and there was no breakthrough. But then there was one gentleman who came into clinic worried about TB, but he had bronchitis, and really his PPD was negative, chest X-ray was done, and didn't show much of anything at the time. But what was most interesting is that when he walked out of the clinic, we saw him shaking hands with one of the guys who we were treating for TB. So we brought the gentleman back into the office and just said, you know, how did you know him? You know, what was going on? And one thing led to another, and he said that he played cards with them. And when we asked about the card game, it was a floating card game, and it was more like a gambling ring that played out at, was played at a local bar. And it wasn't just 4 or 5 guys, and that's, you know, there were hundreds of people, or more than 100 people that participated each week. So prostitution and drugs were also evident. There was a high rate of HIV and STDs that were there when we went back and did an investigation. But the long and the short of it is that we found a very high rate of PPD positivity amongst the patrons of the bar. We went and did an X-ray in the middle, did X-rays, set it up under an oak tree in the middle of the night, skin testing throughout the night. It was an amazing sort of exercise there. But we found that the TB transmission was going on. So that was why they didn't show up on contact lists. That's why conventional epi didn't really help us, because those individuals didn't know everyone at the card game. It was too big, but yet very poor airflow, a lot of other risk factors such as HIV positivity. All these things contributed to significant transmission. What was very interesting, sort of as an aside, I'm sort of a history buff and love history, but what was fascinating is that we found that this sort of drug and gambling ring had been going on for decades, because the county at the time was dry. And really, when this county was actually in the national spotlight back in the 1950s, when there was the story of a black woman who was charged with murder of a prominent white physician, It became a very popular, controversial novel at the time called The Trial of Ruby McCollum, which was banned in Florida up until probably about 20 or 30 years ago. So it spent 20 years on the blacklist and just was not able to be read. It was just a blacklisted book. No one can get access to it. And even now, there are very few copies available in Florida. This is a copy of the play that actually was in Los Angeles and had a long run there for some time. So as Harry Truman said, there's nothing new under the sun except the history you don't know. And this is some more history that we then learned is that it's not a good story until the federal agents are involved. So the feds actually seized the bar, and it is no longer a source of TB, HIV, or STD transmission. So I will end at this time and take any questions about this talk. And I'm the tall one on the right there, and that's my son. And
okay, does anybody have any questions? No questions? Okay, thank you, Dr. Lauzardo.
Sure.